Assalamu alaikum wa rahmatullah. Welcome back, everyone, to our third and last day of our patient safety webinar. So, as we have encountered some of the basic terms regarding the patient safety and the more common issues that can happen to the patients in a healthcare facility, we will now discuss the frequency and the impact of the occurrence of an error in a healthcare system. So, the frequency of an error is in part because of the different definitions and assessment method of various studies that had shown different rates of adverse events. And overall, while early studies has identified the adverse event in approximately 1 in every 10 admissions, recent ones using the global triple tool have also found that the rates can range from 1 to even every 3 cases. So whether this change can represent a true increase in the harm or even a more sensitive measure is still unidentified. And interestingly, overall, the hospital mortality rates have fallen markedly in the recent years, which further highlights the safety measures that has been adapted in recent years. And in any case, given the substantial effort that have gone into improving the safety over the past decade, the adverse event can figure with remaining sobering finding and should cause us to even redouble our effort and make sure that we are on the correct track in order for us to ensure the patient safety to the highest level. And of course, it is not all adverse events that are created in an equal manner, but we are more concerned about the adverse events that result in death or even disability than the ones which lead to an extra day in the hospital or even a delay in a test or a medication intake. So the caveat here is that, as always, that someone near the misses cases can occur in which there was no harm at all, which can illustrate important system problems and have even tremendous learning values for the organizations. So many safety studies uses the National Coordinating Council for Medication Error of the reporting and the prevention index for categorizing the error, which grade the error on a scale of A to I. So many safety studies uses this index as about two-thirds of the adverse event can cause even little or no patient harm at all, and about 1 in every 3 of the ranging from a minor harm to even a prolonged hospitalization to permanent disability. Also, this risk is not evenly disturbed, with some unfortunate patients that have a far higher chance of suffering with significant adverse events. And as one classic study demonstrated, these patients can often experience multiple events. So as we were saying, about two-thirds of the adverse event can cause little or even no patient harm at all, but about one-third can do, ranging from minor harm such as prolonged hospitalization to even permanent disability. Also, the risk is not evenly distributed, with some unfortunate patients having a far higher chance of suffering from a significant adverse event. And also, as one classic study has demonstrated, these patients often experience multiple events. So this is estimated that the average patient in the ICU has about 1.7 errors in their care. And for example, it has been, and on the average that the hospitalized medical patients experience one per every ICU day medication error on a daily basis. So the patient on multiple medication or even on a particular risky medication such as anticoagulant are considered more likely to be harmed as the older patients who are considered as a fragile population. So the financial impact of the medical error and adverse event is enormous. According to the NAM report that estimated the overall national US cost for the preventable adverse event in the late 1990s was between 17 billion to even 30 billion. So as these numbers come exclusively from the hospital-based studies, adding to the impact of adverse events in the ambulatory clinic and the nursing home, which will further have a higher increasement of the cost. So when viewed in this way, it becomes difficult to argue that we cannot afford to fix the problem of the medical error from the start. And historically, the widespread of the fee-for-service payment system in the US has been a part of the problem, as both for the provider and for the institution that have generally gone from institution of the compensated effort or even for unsafe care with little financial incentive to make the request of the investment for a safer system. So the advantage of the accountable care organization and the focus of the population health management on caring for the patient across the continuum can shift the financial incentivity in a way that promote the providers and the institution to invest in the safety. So even in countries and organizational structures that do lose money from the error and harm, doing that accounting to determine the return of the investment from the spending on the safety is considered tricky. Also, many recent policies initiatives are designed to increase the cost of error and harm to the systems and in an effort to promote the investment in safety. And yet, the largest impact of the medical errors and adverse events remains the toll to take on the patients and their loved one, with the best measured in anxiety, harm, and death. Moreover, in so many cases, the provider are considered the second victims of an unsafe system, which let them down when they most needed the support. And for all of these reasons, the moral and the ethical cases for the patient safety remain the most powerful motivator of them all. There is also the modern approach to the patient safety, which is systems thinking and the Swiss cheese model, as we have discussed earlier on. So, historically, the approach to the medical error had been to blame the provider who delivered the care to the patient, who are the one acting at what is sometimes called the sharp end of care. This could either be the surgeon providing السلام عليكم ورحمة الله معلش حصلت مشكلة في الإنترنت. So, as we were saying, the one at the sharp end could be the surgeon performing the surgery, the intern working on the patient's chest, and also the nurse, for example, hanging the IV. So, over the last 2 decades, we have recognized that this approach can overlook the fact that most of the errors are committed unintentionally by the hardworking, well-trained individuals, and such errors are unlikely to be prevented by simply admonishing the people to be more careful, or even worse, by shaming them or by firing or suing them. So the current approach to the patient safety replaces the blame and the shame game with the systems thinking in a paradigm way to acknowledge the human condition, in specific the human error, and also concludes that safety depends on creating systems which anticipate the errors and either prevent or catch them before they can cause any harm. And while such an approach has long been the cornerstone of the safety improvement in the other high-risk industries, the system thinking had been ignored in medicine until recent years. And according to a psychologist who found the Swiss cheese model of the organizational accident has been widely embraced as a mental model for the system of safety. Also, this model, drawn from the accident investigators in the fields such as commercial aviation, as we have been using to give example, considered at the sharp end who's the person in control of the issue that is happening. So instead, such error must be punctuated with multiple incomplete layers of protection to cause a devastating result that can enhance or have a tremendous impact on the healthcare facilities. So the reasons the model highlights the need to focus this on the goal of trying to perfect the human behavior and also to suggest that the greater effort to be directed at the shrinking holes of these Swiss cheese model can have multiple overlying layers of protection, which can help in decreasing the probability that it will even align and even the error can result in harm eventually. So this Swiss cheese model can emphasize that the analysis of the medical errors need to focus on their root causes, not just the smoking gun or the sharp end of the problem, and all these underlying conditions which made an error possible or sometimes a situation inventable can be prevented in the future. Also, several investigators have developed a scheme for categorizing the root causes for any error. So the scheme can explicitly forces those reviewing the error to think about the contributing factors and to also ask for examples, such as whether there should be or have been a checklist or a readback or required for a particular process, whether the resident was even too fatigued to think clearly, or the young nurse was too intimidated to speak up in some cases. So, what is the difference between a slip and a mistake? And even though that we now understand that the root causes for hundreds of thousands of error each year can lie in the blunt end, which is the proximate cause, that is often an act committed or neglected or even performed incorrectly by the provider. So even as we continue to embrace the system approaches as the most useful paradigm, it would be short-sighted not to tackle these human errors simultaneously. And after all, even a room filled with flammable gas will not explode unless someone strikes a match. And when we analyze the human error, it is useful to distinguish the slips from mistake. And to do so, one must appreciate the difference between the conscious behavior and the automatic behavior. The conscious behavior is what we do when we pay attention to a task and is especially important when we are doing something new, like learning to play the piano, for example, for the first time. While on the other hand, automatic behaviors are the things that we almost do unconsciously. And while these tasks may have even require a lot of thoughts initially, after a while we will do them virtually in our sleep as a very simple task. And in addition, the human often prefer the automatic behaviors because they can take less energy and have predictable outcome, allowing us to multitask, like for example, drinking coffee while driving a car, all of which considered simple tasks in general. However, some of these behaviors can feel automatic, but can also require conscious thoughts. For example, when a doctor tries to write a routine prescription, while simultaneously pondering the differential diagnosis for a challenging patient as he is at risk for both making an error in the routine automatic process of writing a prescription, which is considered as a slip, and also in the conscious process of determining the diagnosis, which is considered as a mistake. So the slips are considered inadvertent unconscious lapse in the performance of some automatic task as we absently drive to work, for example, because the automatic behavior kicks in and it directs us to the action. While the slip occur most often when we put on an activity autopilot so we can manage a new sensory input and think through a problem or even deal with some emotional upsets. While mistake, on the other hand, can result from incorrect choice. And rather than blundering into them while we are distracted, we can usually make mistake because of the insufficient knowledge, lack of experience or training, inadequate information, or even inability to interpret the available information properly, or even by applying the wrong set of rules or algorithm for a certain decision. So when measured on an error per action yardstick, the conscious behavior are more prone to mistakes than the automatic behavior are prone to slips. And even though that slips probably represent the greater threat to the patient's safety, because so much of what the healthcare provider is doing as an automatic pattern. So the doctors and nurses are most likely to slip while doing something they have done correctly for 1,000 times, such as asking the patient if they are allergic to medication or to verify the patient identity before sending them to a procedure. So the complexity of the healthcare work adds to the risk of these slips and mistakes. And like, for example, any other field and other trained to work in high-risk occupations, healthcare physicians are programmed to do many of the specific tasks under pressure with high degree of accuracy. And unlike most other professions, the medical job typically combines three very different types of tasks, such as the subconscious behavior with the complex decision and judgment call, and many customer interaction with innumerable automatic behavior that will be implicated. So the physician training in particular has traditionally emphasized on the high cognitive aspect of the clinical practice, which has focused less on the human interaction And until recently, it has completely ignored the importance and the riskiness of the automatic behavior. And with all of this in mind, how should we then respond to all of these inevitable slips? And historically, the typical response would have been to reprimand, if not fire, the person who is in charge of doing the wrong slip to even be more careful next time. And even if this healthcare professional tried to be more careful, they would just be likely to commit a different error while automatically carrying out a different task in a different setting that is in an unconscious matter. And as a researcher has reminded us, the errors are largely unintentional, and it is very difficult for the management to control what two people didn't intend to do in the first place. And whatever the strategy employed to prevent the steps, a clear lesson is that boring repetitive tasks can be dangerous and are often performed better by machines. And in medicine, these tasks include monitoring a patient's oxygen level during a long surgery, suturing large wounds, holding surgical retractors steady for a long time, and scanning mountain of data for significant patterns. So, according to an anesthesiologist who found that observing people who don't need to apologize for their failure to achieve a machine-like standard in those activities for which machines are better suited, and they are good at other things, including original thought and empathy with compassion in another point. So it is true that people are distractible, but in fact, this provides a major survival point or advantage for them. And a machine, unless expressly designed to detect such an event, will continue with its repetitive task while the house burns down, for example, around it. And whereas the most human will notice that something unexpected is going on and will change their activity immediately. So the general principle of the patient safety improvement strategy, it was drawn on these mental models that the today patient safety field emphasizes the need to shore up the systems to prevent or even catch errors rather than to create a goof-proof individual provider. For example, errors in routine behavior, the steps, can best be prevented by building in the readiness and the cross checks in the form of a checklist or read back, as for example, let me read that back to you, and other standardized safety practice such as signing a surgical site before an operation. So this model also emphasizes the need for standardization and simplification of any process. And for example, standardizing the process of taking the patient to the MRI or even to make it faster to the back in the correct safety procedures as soon as possible. And recently, there has been increased emphasis on decreasing the error at the person-machine interface through the use of forcing function engineering solution, which can lower the probability of a human error. And in healthcare, one famous forcing function was to change the gas nozzles and the connector so that the anesthesiologist could not mistakenly hook up the wrong gas to the patient. So, given the ever increasing complexity of the modern medicine, building in such forcing function in device and technologies such as intravenous pumps, cardiac defibrillators, mechanical ventilators, and even computerized order system entry is crucial to the safety of the patient. And in addition to systems enhancement, there has been a growing recognition of the importance of improving the communication and teamwork. So the term of the culture of safety is used as a shorthand to describe an environment in which teamwork, clear communication, and openness about the errors both of other healthcare professionals and to the patient are being operative and used in these facilities. While another key patient safety principle is to learn from one mistake. So this can be implemented in multiple forms, including safety systems that have a culture in which the errors are openly discussed, often in the morbidity and mortality conferences. And there is also a new push to make sure that such discussions include the member of the appropriate discipline, such as, for example, hospital administrative, and point out error rather than the gloss over them in the name of avoiding a benefitive atmosphere, and also emphasis on the system thinking and the solutions. In addition to this, to open discussion at conferences, safe organization can build in mechanism to hear about the error from the frontline staff, often via the incident reporting system or a unit-based safety team, and also to perform a detailed route of the analysis for the major error, including the sensitive events, in an effort to define all of the layers of the Swiss cheese model that we have described previously. So they also can recognize the realities of a complex adaptive system as over managing of the workers through both loads of top downs and also the prescriptive rules and directives, which may be more unsafe than tolerating some degree of flexibility with experimentation on the frontline workers. And in recent years, organizations that excel in learning from their own experience are often described as learning health systems. And finally, there is increasingly appropriations of the importance of a well-trained, well-staffed, and even well-rested workforce in delivering a safe care. And there is now evidence linking the low nurse to patient ratio, the long working hours, and the lack of the board certification to poor patient outcome, which is catalyzing a more holistic view of the patient safety and recognizing that the implementation of a safer system will not create safe patient care if the provider are overextended, poorly trained, or even under-supervised. And neither is the system thinking an excuse to allow the caregiver of their leaders to remain unaccountable for allowing to follow the appropriate and well-vetted safety rules. So, this long list of potential approaches to improving the safety can highlight one of the great challenges in the field, including in the absence of comparative evidence and in the light of the high cost of some of the interventions, such as improved staffing or computerized order entry or teamwork training. Even with organizations committed to safety that can become bewildered as they consider which approach to emphasize even more often. While on the other hand, because improving the culture is both difficult and hard to measure, with its risk being shuffled to the bottom of the priorities and notwithstanding its importance to the safety, to the patient safety in general. An important consideration for the patient safety is the quality. So, according to the National Academy of Medicine, it defines quality of care as the degree to which the health services for individuals and population can increase the likelihood of a desired health outcome, which are consistent with the current professional knowledge. So, in their 2001 report, the Crossing Quality Stamp of the NAM has advanced 6 aims for the quality healthcare systems, including the patient safety, the patient centeredness, effectiveness, efficiency, timeliness, and equality for all patients. Therefore, noting that this framework can despite the safety as one of these six components, which in essence making it a subset of quality. So we should also note that though even many clinicians tend to think of quality as being synonymous with the delivery of evidence-based care, the NAM definition is much broader and include matters that are of particular importance to the patient, including the patient-centeredness and timeliness for the care. This also can include the society with equity to ensure equal delivery of healthcare to all parts of the community. So even though that the NAM can make it clear that quality is more than the provision of care that is supported by science, evidence-based medicine, and thus the provider foundation for much of the quality measurement and improvements in general. And for many decades, the particular practice style of a senior clinicians or prestigious medical center determined with the standard of care and the variation in treatment approach for the same condition that was widespread. And without the discounting of the value of experience and mature clinical judgment, the modern paradigm for identifying the optimal practice has changed, and it is driven by the explosion in the clinical research over the past two generations, which is in which the number of the randomized clinical trial has grown from less than 500 per a year to about 25,000 cases in a year back in 2000. So this research has helped in defining the best practice in many areas of medicine, ranging from preventative strategy for up to 65-year-old female patients with diabetes to treatment of the patient who have acute myocardial infarction and cardiogenic shock. So the health service researcher has found that taxonomy is widely used for measuring the quality of care. And according to the Danbroid triad, it can divide the quality measure into the structure as how the organization or the care is organized, also the process of what was done, and the outcome as what happened to the patient uh, in their process of care. So when used to assess the quality of care, each element of this framework has an important advantage and disadvantage at the same time. The growth in the clinical research has established the link between certain processes of care and also improved health outcome. Because of this, the processes measures have frequently been used as a proxy for quality. An example can include measuring whether a hospitalized patient with pneumonia received influenza and pneumococcal vaccination, and also measuring the glycated hemoglobin level at appropriate intervals in an outpatient setting who have diabetes. So while there is still value in using processes measure to assess the quality in certain circumstances, the field can focus on shifting toward the use of outcome measures such as a 30-day risk standardized mortality and a 30-day readmission rate. And the difference between the processes and the outcome measure is also worth clarifying. These can include if the focus of the measurement was on whether or not the physician has checked the A1C level or the blood pressure, for example, at the appropriate interval, which that measured would be considered a classic process measure. And on the other hand, if the focus was on the actual value of the A1C level, which is the fragment of patient with hemoglobin level below 7%, which would be considered on an outcome of a more specifically intermediate outcome, as it is really considered a proxy for the outcome we care about, such as mortality, kidney function, or even retinopathy. And even though that such intermediate outcome may seem like attractive hybrids between process measures and the true outcome, it is important to appreciate that intermediate outcome, like true outcome measures, may require a case mix adjustment to fairly assess the quality of care. And more importantly, the medical literature is rebuilt with cautionary report on the result of interventions which improve the possible intermediate outcome. And as such, uh, the suppression of the premature ventricular contraction, for example, or the raising level of HDL, but it had no effect or even increased the risk of harm on the main outcome of interest. And where the science of these case mix adjustment is suitably advanced in a cardio bypass surgery, the measure of outcomes such as mortality rate are often used. Also, the caveat is crucial if the case mix adjustment is not done well, as the surgeon or the hospital that accept the case or the sickest patient may appear to be more worse than those of a lesser surgeon or institution which take only the easy cases. And furthermore, the case mix adjustment is often based on the administrative data if the care is not documented and coded adequately. So this case mix adjustment is not reliable reflection of the true severity of any illness. And finally, when the processes are quite complex and the science of the case mix adjustment is immature, then structural measures are often used as proxies for quality. And as with process measures, using structural measures in this way assumes that good research has linked such elements to the overall quality. An example of such structural measures supported by strong evidence include the presence of a dedicated stroke service, nurse-to-patient ratios, and also computerized provider order entry system. And it is also worth highlighting that another special kind of outcome measure can be detected, as we have seen with the NAM appropriately consideration of the patient experience to be one of the key dimensions for assessing the quality of patient care. And accordingly, assessment of such experience generally collected through patient satisfaction survey administered after hospitalization and also after ambulatory visit have become important quality measures both because they can reflect an outcome that we interestingly have or care about and because they may be associated with higher quality of care. And the growing emphasis placed on the patient experience metric is reflected in the Affordable Care Act of 2010, which established the medical care value-based purchasing of the pay for performance setting initiative that financially reward or even penalize hospitals based on how well they do on a mix of processes and outcome measures. So, in its first few years, the VBB placed significant emphasis on the process measures such as administration of aspirin, for example, and more on the recent versions of the VBB, they focused on the outcome measures such as the 30-day risk adjustment mortality for patients with acute risk, such as myocardial infarction, as well as the patient experience, safety, cost, and efficiency. And according to Harvard Business School, the professor has found that we should focus more our attention on the outcome measures as they are what matters to the patient in general. While the problem with using these hospital mortality rates as a measure of the quality and the safety care has made it clear and to the risk of being obvious, the validated processes measures are more useful for assessing the quality of care than bad outcome measures. Also, that good outcome measures don't obviate the need for process and structural measurement in general. And for example, let's say that we find our readmission rate for heart failure patients or our mortality rate for stroke admission are higher than we would desire. So the next step would be to examine our processes and structure and compare them to those of our peers or to the known best practice in general. So this is what we mean when we say that one of the downside of outcome measure is that they are not directly actionable, but they just measure the outcome. And in the end, it is clear that a thoughtful mix of all of the elements and of these triad processes, structure, and outcome is essential for developing a sound program of quality measurement and improvement in general. We will be taking a quick break for 10 minutes and then we will continue discussing the epidemiology of quality problems. Assalamu alaikum wa rahmatullah. Welcome back, everyone. We will continue discussing the epidemiology of quality problems. So, in a series of pioneering studies, a researcher has demonstrated that large and clinically indefensible variation in care from one city to another for the same problem or procedure can have a significant impact. And that variation in the quality of care for patients based on race, income, and gender still persists up to date. So these findings can hint a fundamental flaw in the modern medical practice after seeing such profound variation in the common processes and procedures, as well as in the outcome of comparable patient groups, as we can only conclude that care is often inconsistent with the evidence. So it is stimulated by early studies on the disparities and the variations of the researchers that have more directly measuring the frequency with which the clinicians and the healthcare organization deliver care that comport with the best evidence that is available today. And according to another researcher, they studied more than 400 evidence-based measures of quality and found that practice was consistent with the evidence only in about 50% of the time. And even though that adherence to evidence-based processes can generally correlate with the improved clinical outcome, sustaining adherence after implementing the necessary changes in practices remain very challenging. And that these large differentiations between the best and the actual practice have caused the patient, the provider, and the policymakers to seek methods to drive and support the quality improvement activities. So the catalyst for the quality improvement, as the problem described before, have exposed several impediments of the reliable delivery of high quality care, including the lack of information regarding the provider or the institutional performance, even though that this is changing with the growth of public reporting for certain metrics, and the weakness of incentive for quality improvement, with also the difficulty for practicing the physicians to stay abreast for evidence-based medicine. And until recently, the absence of these system supports, such as the information, the technology for quality, is still missing. And each will need to be addressed in order to make substantial gains in the quality of care. Therefore, the first step in the quality improvement begins with the measurement. And initially, there are only a handful of generally accepted quality measures, and most of which focused on the process of care, such as whether the patient with acute MI received aspirin or beta blockers. And over time, the number of metrics which the healthcare organizations are responsible for has grown rapidly, which can be promoted by a variety of organizations, including the buyers or even the accreditors, as well as the medical societies. And by the end of 2013, the CMS has developed 25 different measurement programs with over 800 discrete metrics, which is a massive increase compared to 2006 when there were only 5 programs with 100 matrix. So while these measures have identified many opportunities for improvement among the individual physician practices, hospitals, and post-acute care centers, these still face tremendous challenges of developing the infrastructure that is needed to actually measure and transmit the required data back to the CMS. So given this enormous amount of new literature that is published each year, there is no individual physician that can possibly remain abreast of all of the evidence-based advances in their given field. So the practice guidelines, such as those for the care of community-acquired pneumonia or for deep venous thrombosis prophylaxis, aim to synthesize the evidence-based practice into sets of summary of recommendations. So even though that some providers write the guidelines as a cookbook of medicine, there is increasing agreement with the standardized best practice, which is ethically and clinically appropriate, while in fact, a high reliability organization hardwire such practice which are updating them as new knowledge accumulates and designing them so that they can easily be implemented at the point of care. And the clinical pathways are similar to the guidelines, but also they attempt to articulate a series of steps, usually temporary. For example, on day one, do the following, on day two, do the following, and etc. So they are most useful for the relatively straightforward and predictable processes, such as the post-operative management of the patient after cardiac bypass surgery or even hip replacement, for example. So after discussing the implementations and processes in the quality care, there is also some challenging in the landscape of quality. So even though that there one could argue the professionalism that should be sufficient incentive to provide high quality care, and providing such care can depend on building a system to reliably translate research into practice, which takes significant investment, such as developing guidelines, physician education, or hiring case manager, and etc. So historically, the buyers can compensate the physician and the hospital at the same, regardless of whether or not the quality of care is delivered that was superb or appealing, which can provide little incentive to make the required investment. So this is changing rapidly with blizzard of initiatives and metrics, including the B4B program, under which the provider and healthcare organizations are paid based on the quality to support or even catalyze the quality improvement activities. And virtually all involve several steps such as defining a reasonable quality measure, evidence-based measure that capture the appropriate structure, processes, or even outcome, in addition to measuring the performance of the provider or system, and also using these results to promote the change. So even though that each of these steps comes with its own challenges, the final one has probably created the greatest degree of uncertainty and has also been subject to the most experimentations. So the first step in the activities designed to promote quality improvement involves selecting appropriate measures for the local quality improvement activities, which is maybe benefit of the processes measure, which seems plausibly connected to an connecting of interest, which is the two that are not bulletproof. So it is also often appropriate to use measures that are captured through self-reporting by the involved provider while also acknowledging the inherent bias in such data. And even though that we all aspire for a perfect measurement, we don't let the perfect be the enemy of the good, which is a reasonable rule for many local quality improvement projects. And on the other hand, it makes sense to insist on a higher standard for measures that are being used for public reporting or even the B4B program. And for example, a researcher have called these high-stake assessment accountability measures and proposed for criteria that they should meet in general. So this distinction is far more of an academic interest, which is the colleagues that have shown, even if the provider check a box of attesting that he or she provide discharge counseling to patients, for example, with heart failure, which is there is no correlation to the readmission rate, and probably because of the quality of such counseling and individual patients comprehension that can vary widely from one physician to another. Also, after the medical care instituted a quality of measures assessing the timing of the initial antibiotic administration for the patient with pneumonia, this 4-hour rule has subsequent studies that demonstrated many emergency department patients who were given antibiotic by the rushed physician later proved not at all to be pneumonia or to have any infection. While another example of this, even though the post-operative venous thromboembolism rate have been incorporated into several pay-for-performance quality improvement initiatives, including the medical care PPP program, the evidence can suggest that the measure can be flawed due to the surveillance bias and that of the hospital with the higher rates of VTE that can simply spend more time and resources doing unnecessary imaging. Therefore, it is clear that we have much to learn about which measures to target and how to collect the data, and also how to promote improvement at a reasonable cost and with also minimum of anticipated consequences. And once we settled on appropriate measures, the next step involved promoting and also supporting improvement to make this a lasting intervention. And even though that one might hope that clear feedback will generate meaningful improvement in a provider performance, the experience has shown that this strategy leads to only modest change. And increasingly, a strategy directed at transparency, which is disseminating the result of quality measure to key stakeholders, is becoming the norm in most hospitals. And with simple transparency, the hope is that the provider will find the public dissemination of their quality gaps to be sufficiently concerning to even motivate for improvement. So many believes that the patient or their proxies, such as third-party buyers, will begin to use such data to make choices about where the patient receive care. And up to date, even though that there is little evidence of the patient who are using such data to make purchasing decision, the study showed that impressive improvement in some of the publicly reported quality measure supporting the premises and the transparency itself can generate a change. And according to a researcher, it is useful for considering the two interwoven pathways of selecting by the patient or the purchaser and the changing or change the undertaking by the provider organization, even though that which measure and the transparency can stimulate improvement in general for the patient themselves. And increasingly, the program can tie the payment for the service to quality performance, which is under the B4B program, which are being utilized to motivate for improvement. And even though that this program conceptually is attractive, it raises a number of questions. Are the quality data accurate? Should the payment go to the best performer or for those with the greatest improvement? This is still unidentified. Also, if the existing measure can adequately assess the quality to the patient with complex multi-system disease or not, is it another important thing to consider. And if the B4B educate the professionalism or even create undue focus or even measurable practice and relative inattention to other important processes that are not being compensated for, as it has yielded only marginal change in the quality beyond that generated by the public and also of the quality reporting systems. So some can suggest that it makes a real difference with these programs that are required in large financial incentive and improve in the program design. But there are numerous P4B programs that are currently being experienced and tested for implementation in healthcare facilities. So one of the notwithstanding of the mixed evidence of effectiveness is the emphasis on the B4B that is continuing to grow, especially at the individual physician level. And according to the Medical Care Access of the CHIP Reauthorized Act that was passed on the 2015, targeted the medical payment to the physician as an assessment point. So combining several existing quality reporting programs into one framework of the physician quality reporting system and the medical care of the electronic health record all can provide a unique perspective under the incentive physician provider of the high quality care and facilitating the Department of Health and Human Service goal that is tying the majority of medical payment to the value and also increasing the amount of medical care payment that are associated with alternative payment models. So what are the strategy for quality improvement? So whether the motivation is ethical, embarrassment, or even economic, the next question is how to actually improve the quality of care. There is no simple answer to this question, but most of the institutions and the physician with the success in this area use a variation of plan, do, study, act cycle that we explained earlier. So in this cycle, they recognize that quality improvement activities must be carefully planned and implemented with their impact that need to be measured, and also that the result of this activity need to be fed back into the system in a continuous iterative process and improvement steps. So a number of more complex and sophisticated methods have been developed in this business, where manufacturing or engineering industries adapted these steps, and also healthcare has taken these strategies and implemented them in hospital setting, but not always with success. So a detailed discussion of these methods include the commonalities and the differences between the quality and the patient safety. And even though the patient safety is considered a subset of healthcare quality, it is important to appreciate that sometimes subtle differences between the two areas, in particular when it comes to measuring the performance and changing the practice and the system, is worth noting or mentioning. For example, if we have a 75-year-old man who was admitted to the hospital with severe subtle chest pain, in the ER, they ordered ECG and blood tests to test for their occurrence of myocardial infarction. So there is a strong evidence linked of the door to balloon time to the patient to ultimate outcome of the hospital. And in this case, any delay in reaching these results can lead to delay in the patient discovery of their issue and also their discharge and treatment. So in this example, the patient physician forgot about the X-ray that was performed and therefore discharged the patient before the result was disseminated and has led to a major error in the patient condition and developing of a worsening condition after a few months later when the physician returned to the same hospital with severe condition. So there is no overt error in this process as it just looks for the long as it have of the lack of the coordination, the planning and training. So differentiating of the quality and the safety problem is important consideration. That is because how the best can to prevent them, assuming that the patient insurer has interested, for example, in measuring such issues. And it would be relatively easy to implement a transparent, auditable process to document the time that this patient has spent in the OR or ER, for example. So the public reporting of these timing can perhaps be accompanied by a higher reimbursement for better performance that would likely spur improved performance in general in the healthcare facilities. So a strategy for the public reporting for the medication error can leave the provider reluctant to even report them, causing the system to underaware of such errors where the occurring in the ill-prepared to generate the shared knowledge as well as the money, which will fix the issue in general. So the process of fixing both the problem and the door to balloon time of the medication error can be relatively similar. Both are likely to require change in the core processes, even though that the implementation of technology can perhaps with an automatic ECG reader or any other errors with changing in the culture of the system leaders and the simulation training can all have a beneficial effect on these processes. And at the end, if the patient have the right to expect the care that is both of high quality and safe, then according to the NAM report of the medical error, the error is a human factor that is helped by catalyzing the national push to even improve safety and has led us to important changes in culture, training, regulation, and also technology. And because of that, measuring the safety tend to depend so often on the provider reporting and the retrospective chart review. These strategies of transparency and differential payment are more likely to improve the quality than the safety itself. And happily, the two endeavors has enough communalities where the need for improved information system, standardization, and simplification with using multidisciplinary team and improved cycle than that of the quality improvement initiative that will often result in better safety for the patient in general. While other cornerstones of the patient safety, such as the creation and the safety culture, can be largely independent of the quality improvement factors or errors that would require distinction focus on specific inputs. So the values surrounding the connection of quality and safety to the cost of care. So outside the world of healthcare, we can base most of our purchasing decision on the perception of the value. That is the quality divided by the cost. And all of us will need to have a focus on our consumers' ability that is spent on trying to determine the value of the things we are considering buying, whether it is, for example, a house or college education or anything, by weighting the measured or perceived quality against the cost itself. So the healthcare decisions have traditionally not been made this way, in partial because of the limited ability of the patient and their doctors to make the rational judgment about the quality of the given care or physician or even hospital, and partially because of the one of the functions that healthcare insurer is to shield the patient from of the full cost of their purchasing decision. So, in other words, when we are buying, for example, coffee, we are aware of the price in a perfection position to judge whether the quality and the safety of this item is worth it or not. So, the same implication in healthcare, where the service is often covered by the patient who's responsible for only a portion of the cost with advent in the population health. This program of the Accountable Care Organization can slowly change these perceptions. So much of the decade-long revolution in the quality measurement and reporting can be seen as an effort to provide the patient or the interested parties or even the employer for insurance companies with the information they need to make rational decisions about any healthcare value. And this framework become even more important as the cost of healthcare continue to rise in recent years, crowding out the resources for other worthwhile private sectors and public pursuits. And increasingly, the effort to improve the quality, the safety, and the patient satisfaction are not taking place in a cost agonistic vacuum. Rather, the healthcare provider and organization will be pushed relentlessly to improve both the numerator and the denominator of the value equation. And in this environment, we can already see the incentive shifting from promoting the best care to even promoting the best care at the lowest possible cost. And in both the medical care, value based purchasing, and also the no pay for error initiatives, anything but perfect performance can lead to reimbursement of the cuts rather than additional payments for top performance. And the provision of the payment that is tied to some type of the B4B program initiative for both the hospitals and the individual physician will undoubtedly continue to increase in the years to come. We will be taking a break now for a Maghrib prayer, and then we'll continue discussing some of the basic terms, concept, and epidemiology process. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, back in the 1995, a middle-aged man was named Roman, as a physician in the US had become or witnessed a patient with a chest pain. This physician suspected that the patient has angina. So this is an example. And despite the advances of the electronic prescription at the time, there are millions of participation of prescriptions each year, in particular of the ambulatory setting, that are still considered as handwritten prescriptions, which can be considered as a major source for errors in understanding what is written or misinterpreting the dose. And therefore, this can almost in every situation lead to a negative impact on the patient's health regarding the appropriate doses or something like these. So the modern pharmaceutical representation of one of the healthcare greatest advantage, which are now highly effective as agents to treat or even mitigate the effective of most common medical conditions, such as, for example, hypertension and etc. So if these medications were taken correctly, then their benefit would outweigh their side effects, even though that some of the side effects remain as a concern even when the medications are prescribed and taken correctly. And with the growth of the medication prescriptions, that there are about over 300,000 over-the-counter products that are available worldwide, with prescription that approximately 60% of adults are taken with some of their medication. This had led to huge increase in the complexity and the medication prescribed and administration process in general. It has also been estimated that at least 5% of hospitalized patients can experience an adverse drug event, that is harm experienced by a patient as a result of a medication from either the side effect or the consequence of an error. This can occur at any point during their treatment process. While another 5 to up to 10% can experience a potential adverse side effect, meaning that they nearly took the wrong medication or the wrong dose, but they didn't, often thanks to a last minute catch up or even sheer luck. Also, the elderly patients are particularly vulnerable to such error. Almost half of all nurse income and are exposed to inappropriate medication intake. And this cost of the preventable medication error in the US alone was estimated to be 16 billion annually in 2014. And according to a surveillance study, it estimated that 4 emergency department visits of adverse drug event occurred per every 1,000 patients annually, which represent over 25% of these visits that are required for hospital admission. And in addition to this, approximately 4.5 million ambulatory visits occur annually due to adverse drug events. And historically, many discussion about the medication error has focused on the famous illegibility of the physician handwriting, but also as a result of the rapid uptake of computerized provider order entry systems and the electronic prescription that is simulated in most hospitals nowadays. So there are many steps along the medication prescription and administration pathway that are vulnerable to mistake at any step of such processes. And not only might the prescription itself be prone to error, which is wrong medicine, wrong dose, or any other issues, but also the administration of the medication that is generally mistaken in the pharmacy need the proper monitoring and checking every prescription to ensure that everything is written in the correct format. So, for example, the patient's ability to take the medication correctly and the caregiver ability to administer the medication correctly, or even the ability to take the medication at all for that matter, are all considered as vulnerable steps that can happen with mistakes at any time. And in such complex system, the statistical law inventable can take it a total of about 50-step process in which each one is done correctly about 99% of the time, and the chances that at least one error will occur that is staggering to about 40% chance of such errors. An example of this is the case of an 70-year-old female patient who had undergone a cardiac bypass operation. And after the operation, she seemed on the road for recovery, but on the morning of her planned ICU transfer, she suffered from grand mal seizure. After assessing the patient and their medication intake, this error has occurred as a result of medications that are similar in appearance and had a negative impact over this patient's health and condition. So, as this case demonstrates, the mitigation of the problem of the medication error requires solutions that address the steps that are involved in both the prescription administration phase and all of the phases following that. And many of the solutions have been increasingly adapted over the fourth decade of the technologies that can be implemented in these cases. So the solutions that are more specific to the medication prescription and administration process, this has a standardization guideline for the 5 rights, including to double check, prevent of the interruption, and also distraction with unit dosing, removal of risky medication from certain settings, and the role of the clinical pharmacist and meeting such challenges in everyday healthcare setting. So, what are the strategies to decrease the medication error? This includes standardizing and decreasing the ambiguity related to the drug administration and use. An example of this is the popular health columnist who hospitalized for the recruitment breast cancer studies, as her experimental protocol called for her to receive an unusually high dose of this medication. So the ordering physician wrote the right medication, but in a wrong dosing system, which the nurse interpreted as a higher dose than that was intended, therefore leaving the patient to suffer from the complication following that negative administration. So underscoring the need for standardization in this process with agreement on the invaluable ways of communicating certain medication order that would be understandable to everyone who is involved in the patient care. So an example also of a hospital that could mandate that all medication given for a specific or multiple doses system must have a daily dose written each day so that any mistake can be detectable over a period of time. And one source of ambiguity has been the long-standing use of abbreviation for certain medications, as in 2004, the Joint Commission has prohibited hospitals from using a group of high-risk abbreviation and replacing them with a more relatable or unit dosing that cannot be mistaken in any condition. So while many advances in the medication safety have come from the system changes such as automation and double check, there is also individual caregivers who are responsible for doing what they can to ensure the safety of their patient. So on long-standing nursing principle that is known as the 5 rights tools for highlighting the 5 checkpoint that a nurse is expected to make before administering any medication to patient. So these have some argued that additional check, including the right documentation, right action, that is being given for the correct indication with the right form and response should be monitored for the patient response. With some still adding another, the right of the patient to refuse the medication as an integral step in this process. And even though that these additional rights have not yet become standard practice, they can further illustrate on the correct medication administration and also the limitation of human vigilance as a safety bulwark. Another strategy is to double check. With other high risk industries, for example, aviation, they have long used double check and even triple check to ensure that the critical processes are being conducted in the correct manner. So the only processes with standardization and inviolable independent double check in the most of the hospital was that of the blood administration. But also that most hospitals now have built-in double check for high-risk medications or treatments such as chemotherapy and other medications. And even when double check are required by policy, it is critical to ensure that they are truly independent. So it is very easy to conduct for the second check to become even a lack social in exchange for a rubber stamp, thereby providing false reassurance rather than truly increasing the safety of these medication intake. Another important strategy is the prevention of interruption and distraction during the medication administration. So each step in the medication prescription, preparation, and also administration process is subject to error in most of the cases. And while that automation has been introduced into every phase of the vast majority of medication delivery, it is still involving human in each step of the process. For example, even in a hospital with computerized order entry, the physician still need to decide the medication and the dose, and the pharmacist need to take the order and dispense the medication to the floor, where the nurse then collect and administer the medication to the patient. So in each of these steps, it is subject to mistakes, and recent research has quantified the extent to which distraction and interruption increase the probability of error occurrence. And most of the research has focused on the nursing portion of this chain, even though that there is little reason to even believe that the prescribing physician or pharmacist are any less susceptible to the hazard of the interruption and the distractions. And in a one-time motion study, they found that nurses preparing and administrating the medication found to be on an average of 1.2 interruptions during every time the medication is being passed. And in a more example of this, it took one nurse 2 hours to retrieve one particular medication and give it to the patient. And in one study, every time a nurse was interrupted during the preparation and administration process, there was about 12% increase in the clinical error occurrence. And emerging evidence is demonstrating that decreasing or even eliminating the distraction and the interruption can improve the medication safety in general. And in one hospital study, they found that the nurses were given protected hour during which they were not to be distracted by telephone call or any other method. And while the study didn't isolate this particular intervention from the several others, it did find a significant decrease in the medication error occurrence. And another hospital created a no interruption zone marked off by a tape on the floor to indicate that critical care nurses was not to be interrupted during their process. So the establishment of this no interruption zone was associated with 25% reduction in both the interruption and the administration errors. Also, before we get even too excited about this intervention, it is worth heading that cautionary note of a researcher who pointed out that certain interruptions are crucial to the delivery of high quality and safe care to be implemented in these steps. They also argued that banning the interruption can outright, as the intervention need account for the complexity of the healthcare system that they need to adapt to. So this is an important argument to consider, as it is easy to see how certain strategies to eliminate the interruption could lead to unintended consequences of squeezed balloon time and interaction with the patient. Where in a 2014 systematic review of the value for reducing the interruption and also during the medication administration found a weak evidence in supporting of this strategy. As obviously, one cure for the interruption and distraction would be to remove the human from the medication prescription and delivery process. And while the automation is likely to do that for some degree, people will remain active and necessarily participating in the medication prescribing and administration pathway for the foreseeable future, as this makes continued attention to these innovations that are essential. Another strategy to decrease the medication error is regarding to the unit dosing. So this refers to the packaging of medication in a ready-to-use unit that are prepared in the pharmacy and then delivered to the ward. So the unit dosing was developed in the 60s, replacing the old method of the pharmacy that sent a large number of medication to be prepared in the ward itself. And studies has generally found that the unit dosing administration is also associated with fewer medication error. And many pharmacy systems now include automatic dispensing machines, which are usually computerized. So the removal of medication from certain settings has been most widely cited, and example for this strategy is the removal of the concentrated potassium from the patient care area, as because of the lethality for this medication that can be caused by the side effect or the wrong use of this medication. And rather than having the nurse add the potassium to their IV solutions on the floor, the new medication has a prepared formula that can be used immediately. So this approach is an example of a more general strategy that is called forcing the function, which is a technical or physical obstacles designed to decrease the probability of error in an error-prone circumstances. So forcing functions are designed to anticipate the common human error and make harm from them impossible by blocking either the error or its consequence in general. So the most widely cited example of forcing function was the re-engineering of automobile systems that were working while the device or the machine was working. So the removal of this concentrated potassium from the clinical setting resulted in removing the source of the error. And because the potassium was still allowed in the ICU, these happened to be some exchange between other wards. Therefore, in the new days, it is completely banned from being in the ward and only prepared in a pre-prepared formula or in the pharmacy. Another important point to consider is the use of the clinical pharmacist as of all strategies employed to try to decrease the medication error. The insertion of a clinical pharmacist into the medication prescribing and administration process is one of the most powerful methods, in addition to having the pharmacist read the prescription and implement it. So, an example of this is a study where a clinical pharmacist became a part of the ICU team and resulted in a better administration of all medication, with reducing the occurrence of error for a large number of the patients. So, meeting the challenges of lookalike and sound-alike medication can also be avoided with the implementation of this approach. And even though that the FDA tried during their drug approval process to have or minimize the appearance of the names that are similar, this still cannot be implemented in most of the medication nowadays. And there are a number of strategies to help in minimizing the risk of confusion, including the use of Tollerman lettering for the suffix of some of the medication that can be mistaken in some situations. So the eradicating of this problem entirely would require technological help, in addition to including a barcoding administered system, in addition to computerized order entry with the decision for support. An example of this is an imaging system that would ask for each medication indication and book if the indication was, for example, seizure, and the chosen medication was Cerebroflex. Another yet important point is the medication deconsolidation process that need to be considered. So this has emphasis on the medication safety when the patient is static in an ICU bed or even in a medical floor. And the greatest opportunities for error in the medication process is likely to come when the patients are transitioning from one setting to another and being admitted to a hospital, for example, ongoing from their primary care physician to a larger hospital care facility. So studies has also showed that unintended medication discrepancies are common and occurring in about 30% of patients at the time of admission. So a similar percentage when they transfer from one hospital site to another, and this corresponds to 14% of the cases in the hospital discharge. In addition to the medications is the process of reviewing the patient's complete medication regimen on both ends of care transition and in an effort to avoid the unintended inconsistencies in these medication intake. And while many physicians have for long asked their patients to bring their old meds with them to the clinic, they can now view these as become formalized relatively recently. And the research for the optimal method performing the reconciliation gained a considerable attention in 2014 by the Institute for Healthcare Improvement. And following year, the Joint Commission had named the medication as one of the national patient safety goals as the organization added it to the requirement for hospital accreditation. But unfortunately, while medication deconsolidation has great phases of the validity for the method, for the accomplishing of it varied widely, and the research on it has produced mixed results. In addition to this, the methods that have included having the pharmacist perform the entire process involving the patients, in particular in their own reconciliation and embedding the process to the electronic system can have some effect. Also, a subsequent randomized controlled trial showed that about half of the adult patients who received a pharmacist-driven intervention involving the medication at the time of the hospital discharge still experienced a clinically significant medication error. But the literature has generally seems to suggest that integrating the pharmacist into the medication reconciliation process is helpful and may even be cost-effective for most of the settings. And while the research is beginning to illustrate some of the best practices in medication, it has also uncertainty about what it really works and remaining with the most successful study to illustrate the beneficial effect of the potential adverse drug interventions. There are also two reviews on inpatient medication concluded that even though that the pharmacist-led intervention could mitigate the medication discrepancy and potential adverse drug interventions after the discharge, with the clinical impact of these discrepancy was even small, and therefore these medication by itself may not significantly reduce any adverse event, or even redness. In addition to this, many institutions have seen their medical reconciliation initiatives because of the disagreement on the crucial issues such as whose job it is to perform this part of the process. And in the light of this uncertainty, the Joint Commission has gone back and forth on the medical requirement, softening the enforcement, but also with these challenges, these can vividly illustrate how difficult it is to implement even a relatively simple fix in a highly complex hospital system. Another important point to consider is the conservative prescribing. One of the key to minimize the medication error is to limit the use of the medication to situations in which they are truly indicated, meaning that when the potential benefit of the patient exceeds the risk of the side effect of the medication. So, as example of this is the elderly hospitalized patient who receive medication that are considered inappropriate for their prolonged use and have a nearly twofold increase in their odds of an adverse event during their hospitalization. A researcher has outlined that a series of principles for the conservative prescribing, and they were well worth the following. As there are more than 20 million people undergoing surgery every year in the US alone, and surgery was considered as extremely dangerous part of the operation, owing because to the risk of the association with the risky surgery itself, and in part because of the risk of the anesthesia on the other hand. So because of the safety advances in both of these fields, surgery today are considered extremely safe and anesthesia-related deaths are very rare. But nonetheless, a number of troubling surgical safety issues can persist. As with the medication error, in which the problems from the intervention are grouped under a broader term, which include both error and side effects, with some surgical complication occurring despite the impactable care, while others are caused by the occurrence of error. So the surgeries can account for a relatively high percentage of both the adverse event and also the preventable adverse event. And for example, one of the major chart review studies of adverse events found that about 45% of all adverse events were in surgical patients and 17% resulted from negligence. So looking at another way, 3% of the patients who underwent an operation has suffered from adverse events, and half of these were actually preventable. While another systematic review estimated that about 1 in every 20 surgery patients has experienced a preventable adverse event, and most of which were actually related to the preoperative care of the patient. So the field of surgery has also taken safety extremely serious compared, for example, to other parts of indications. And in the early 20th century, they found that it was among the first healthcare institutions to measure the complication of care and approach them in a scientific manner. And the end result for hospitals following every patient for evidence of error in the treatment and dissemination of results of this inquiry was both revolutionary and highly controversial. This was in part due to the action of a pediatric surgeon who was largely responsible for bringing these issues of patient safety to the forearm in the presentation of the field of surgery safety. And despite the remarkable contribution, surgery, like the rest of medicine, has traditionally approached the safety as a matter of individual excellence when a complication was deemed to be or representing a personal failing on the part of the surgeon or the shift in the focus of the system improvement that has catalyzed major advances in the surgical safety today. Another important consideration in the patient safety field is the volume outcome relationship. So, beginning in the 1970s, they demonstrated a relationship between the higher volumes and the better outcome for certain surgeries, which is a substantial literature that has gone generally supporting the commercial notion that when it comes to procedures, practice can make perfect. So, this precise mechanism of this relationship has not been elucidated yet, but it seems to hold for both the volume of the individual operator and also the institution, such as the hospital surgery center. And even though that much of the volume outcome relationship has probably owed to the fact that team can take time to get learning of the anticipating of other reactions and preference, there also seems to be a learning curve for the procedural competence. And one of the best studied examples is that of the laparoscopic colostomy procedure that is essentially replaced the more dangerous and costly open colostomy in the early 1990s. So as lap chole emerged as the preferred procedure of gallbladder removal, 10 of thousands of practicing surgeons needed to learn the procedure well after completion of their formal training providing with this. So the finding has showed that lab colleagues showed that injury of the common bile duct dropped to about 20-fold in one surgeon. And after that, learning the curve has flattened, but not much, with even more practice to be done, including reducing the risk. And nowadays, the patient have no such reassurance to this risk of this procedure. As according to a study, they found that only about 50% who participated a 2-day training period resulted in an improved outcome outcome for their surgical interventions. And part of the solution to the volume outcome and the learning curve can contribute to this development of initiative for training models, including the use of medical simulation processes. And in one study, they found that surgical residents who underwent simulation training until they reached their predefined level of proficiency were about one-third as likely to commit technical errors during any procedure that was received during their training. In addition to this, some surgical and procedural specialists are now requiring minimum volume for the prevailing and broader certificate, with also major collating of the bars for the promoting of the high volume centers interruptions. Also, the insurance can insist on a minimum volume for certain procedures to be implemented in the insurance company, and the patient may not be as anxious, for example, for these procedures. And many of these surgeries being discussed, such as cardiac transplant, are relatively lucrative. And losing them could even be threatening to the economic viability of the low volume institutions. And with all of the discussion regarding the patient safety, it is important to remember that procedural skills still matters. And in a remarkable study that was published in 2013, they found that videotaping of those performing surgery were far more likely to be implemented by the ones receiving the higher level of training and implementation in these issues. We'll be taking a break now for Salat al-Isha, and then we'll continue, inshallah, with discussing the patient safety in anesthesia. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, one of the major sources for error in the patient safety is the anesthesia-related errors. And even though, according to the modern patient safety movement, the Human National Academy of Medicine has a noteworthy experience in the field of patient safety. And anesthesia began focusing on safety on a generation that is much earlier than that of the rest of the medical field. And similarly, even before that, it has been troubled that mistakes were common and cover up also occurred in some of the related fields. And an example of that is that noticing that turning the dial clockwise increased the dose of anesthesia in some of the anesthetic machines. Therefore, this was a compatible source of error that they noticed earlier on and made the appropriate intervention. And around the same time, this was in the midst of the malpractice crisis that was characterized in many fields of medicine. And some of the common themes were identified, including a poor machine design, lack of standardization, lack of policies, and even clear procedures, in addition to inadequate education for some of the cases. And even though that research and insight from these examples has closed case analysis were crucial, there are improving in the safety in practice that wouldn't be possible without this widespread engagement of physicians. And luckily, so often it happens that the right person emerged at the right time. And this was the case with the Society of Anesthesia that motivated the experience of their making the care that is safer for the patient safety field. So the patient safety worked closely with other professionals, healthcare, and industry groups that helped in propelling the field forward. That is first by convincing the caregiver that the safety problems were real and that it was also solvable with the right approach. So the lessons from this safety movement are broadly applicable to effort a directed improvement in the overall patient safety engagement in general. And first, the safety can require strong leadership characterized by commitment to openness and willingness to even embrace the change. Also, that learning from past mistakes is an essential part of the patient safety. And in cases of anesthesia, the closed case review produced key insight into what can be done to improve these procedures and processes. While although that technology is not the complete answer to safety, it is also considered as an essential part of the solution. And in anesthesia, the thoughtful application of oximetry, capnography, and automated blood pressure monitoring has proven to provide vital life-saving techniques to improve the outcome on the patient. And where applicable, the use of human factors, engineering, and forcing function can markedly enhance safety in general. And an example of this is changing anesthesia tubing so that the correct gases couldn't be hooked up. That was a crucial step in the safety improvement. And finally, anesthesia found itself in those areas of malpractice crisis and simultaneously had grappled with a number of highly visible errors that were reported in the media. Also, sparks in this area are often necessary to disrupt the interior and the denial that can undermine many of the safety efforts. And for example, in the 80s, an archaeologist paid an exorbitant rate for malpractice insurance among the highest of the medical professions. But nowadays, as the error causing the patient harm are so unusual in the field of anesthesia, the current malpractice premium falls in the mid-range of all specialties. Also, another important consideration when assessing any issues relating to safety regarding surgery are when the wrong patient or wrong site has been used as an issue in specifically in amputation or kidney removal techniques or any other issues that can identify a wrong site or a wrong patient that has drawn the attention for many policies to be implemented, and even like these, which are errors that can have been doubled even as a never heard of event. And studies that also consider the outpatient surgery and the non-surgical procedure have given a higher estimate for the occurrence of these errors, as this can also occur with not identifying the patient identity before giving a medication in the ward, or also when administering chemotherapy, or even when renal replacement therapy. So this can all affect the dose of the patient that they receive and also the type or method of administration in which they should be using the medication. And in essence, the protocol acknowledged that single solution to this problem are destined to fall, and that robust fixes can depend on multiple overlaying layers of protection that can be used for these categories. So, but in earlier history, signing your site can demonstrate a clearly simple solution for these errors that can occur with amputation surgery in specific. But this can also have some problems that were not documented in the cases of wrong site. And even today, the effectiveness of site marking depends, of course, on its correct implementation and the learning process, with another key element of the universal protocol, that is the timeout, during which the entire surgical team is supposed to huddle and briefly discuss. So it seems like a safety solution that is fail safe and can prevent the occurrence of complicated issues. And without safe culture and good communication, interventions such as timeout can be robotic and providing the illusion rather than the reality of safety. And while it is of a component of the universal protocol that made sense and likely with some improvement in the surgical safety, it is yet another example in which more holistic approach can be used, where the past several years it has been having a high number of successful experiments. And the first such effort was in the 8 Hospital International study, which combined the use of the WHO surgical checklist for safety with variety of other activities that were designed to improve the teamwork and communication skills. And while the result of these interventions decreased 50% in death and complication at both the well and the poorly resourced hospital, which were impressive, then the study of validity have been questioned in light of before and after design. And reassuringly, even more comprehensive surgical safety intervention can be implemented, with patients participating hospitals that had about 30% fewer complications and 50% lower mortality rate. And as in the seminal study of the Michigan ICU that was used based on a checklist intervention, resulted in a major decrease in the central line associated blood stream infection. And the WHO investigator has subsequently demonstrated that improvement in these issues and the safety culture can correlate with improvement in the surgical outcomes. Also, study of the implementation of teamwork training has found striking improvement in the surgical mortality. Also, a study of the implementation of teamwork training along with the checklist in about 70 hospitals found striking improvement in the surgical mortality along with evidence of dosing. And the more recent study looking at the impact of mandatory surgical safety checklist found that complication and readmission and length of stay were improved in general. Also, the author of the original WHO study has cited this design, noting that it may not have been adequately powered, but the use of other checklists in the surgical safety procedure can be very important. And the reason for this variable impact may have been the elucidation by the English checklist study that found implementation of these stories. And this literature can make it clear that checklists are part of the answer, but not the only part. And due to issues related to checklists, teamwork and culture have become so central to the entire field of patient safety. While yet another important point to consider are the retained object or instrument in the patient after surgery, with multiple improvement or strategies to help implementing or preventing these issues, including counting before the implementation and designing a particular healthcare professional for the counting of the surgical team. And also, unlike many other safety problems, the retained sponge or instrument problem would seem to be preventable by a thoughtful implementation of systematic review of such issues. And when the operation is over, for example, a nurse can hover the sponge or this counting procedure to indicate any missing items. Also, many manufacturers tried other approaches to produce surgical sponges with these mechanisms, but in most cases, they were expensive and inability to implement them in every situation, requiring more health workers and even more advanced technique to be implemented in these cases. And with the chaotic and pressure circumstances in most ORs, this seems like an inability to be implemented. So it means that every instrument that was accounted for, despite the fact of the one that would turn up later rather inconveniently in the patient, would have real lessons from all of these that initially appears to be perfect logical safety practice that often return out to be highly flawed. And even if, for example, X-ray were free and the patient staff were willing to put up the procedure and additional radiation exposure, it would take too much long time for the surgery to be over, therefore affecting also the patient outcome after the recovery. And ultimately, the best solution is the retained foreign object problem probably lies in new technology that is yet to be identified or developed. And others still have automatic sponge counter resembling the tool-ball coin machine that can be implemented, even though that experience with this technology is still limited. And in a decision analytical model, both of these sponge and radioactive instrument seems like a time of use for radio frequency. And the cost saving for such machines or advances can be very costly on the hospital system, where other solutions seem to be less expensive. So since the diagnostic error can be accounting for 17% of the preventable error, these can be according for mistaking and continue to conduct a significant amount of preventable harm to the patient, even with review of malpractice claims that were indicated. And as the field of patient safety evolved, the Montium for addressing this problem of diagnostic error has now been viewed as a critical patient safety issue that is growing. And in response to this report, they concluded that the vast majority of patients will still experience diagnostic error at some point and can suggest that greater collaboration among the stakeholders is required. Therefore, emphasizing the need that accurate measurement of diagnostic error can outline opportunities to improve the diagnostic process and also reduce errors. So this report also emphasizes on the need for accurate measurement of diagnostic error and outlining the opportunities for improving the diagnostic process and reducing error. And at a first glance, the diagnostic error would seem to represent human failing that is purposeless in cognition. And it is true that the patient safety perhaps more likely than other area in the training and skill of the clinicians remain of paramount importance. Also, keeping with our modern understanding of the patient safety, these are the system fixes that can actually decrease on the frequency and the consequence of the diagnostic mistakes. Another yet important method is the misdiagnosis for some of the cases. And one of these major issues is the misdiagnosis in the case of any heart-related issues in female patients. So this can be due to the fact that these symptoms can be less severe than that compared to men, and it is less common. Therefore, it can be regarded as a nevertheless diagnostic costochondritis that can have impact on the patient mortality rate. So guessing that the chances of the patient having a heart attack couldn't have been as compared to that of patients who are males, and improving the patient safety in regard to misdiagnosis can be of crucial importance, in particular for heart disease. So even though that the patient lab data can be non-specific at time, these were clearly abnormal, therefore they should have considered more time on these impacts. Also, about 1% of admission for acute MI can represent a breeder miss of the diagnosis, and these best studied diagnostic error will use it to make several broader points to avoid these errors. So we are also mistakenly sending patients home who have raising question for conscious or unconscious bias, as one study has assessed that the racial or the bias of the conscious or unconscious bias in the diagnosis, and found that females and Black males are more likely to be discharged or sent home without acute or accurate diagnosis for their condition. Also, the researcher found that the physician-specific differences were also at play, and older physicians had better diagnostic skills than younger one, where some studies have showed that the risk of aversion was not simply a function of age. And about 119 physicians completed a questionnaire assessing their attitude toward the risk. And doctors who appear to be more of a risk taker were found to be 4 times more likely to send the patient home without accurate diagnosis. So improving our ability to diagnose the patient who comes to ER with the outpatient clinic who have consideration of symptoms or finding and even risk factor can yield ambiguous results that can be life-threatening in some of the cases. And too often, without any systematic approach, the clinical decision to admit or even discharge the patient or to provide particular intervention or treatment is based on the physician's faulty reasoning and improvement. So what are the factors to improve the diagnostic reasoning? So sufficient it is to say that computerized adjustments are likely to help the clinicians make better, more evidence-based decisions, but it will not be for the foreseeable future to replace the clinician mind as the main diagnostic workhorse. So can our cognitive bias be overcome, perhaps more than that of any other clinical medicine area, when the diagnostic patient we need to learn from our own mistakes and to also deepen our understanding of the clinical reasoning? And as with most error, the answer will come through system thinking, but there are some better systems for also training the physician to avoid the common diagnostic speed bumps. Also, as the Canadian safety expert and emergency medicine puts it, one uniquely distinguishable characteristic of those who have or make high quality decisions is that they can largely free themselves from the common pitfalls of which no voice are vulnerable. Also, the passage of all disciplines of medicine is learning about the clinical pitfalls that have been identified by the discipline expert. And this says, in effect, that here is a typical error that will be made here if it, or it can be also avoided. So interestingly, in the case of the chest pain triage decision, most of the experts can conclude that the quest for diagnostic certainty is futile in most of the cases. And in a number of research studies, even the best algorithm could not be reliably identifying the patient whose actual risk was so low that it was safe to send them home, especially when the penalty for even occasional failure might be tragic death and multi-million-dollar lawsuits. So the real progress in the chest pain triage has come not from the honing of the diagnostic ability, but rather from developing ways that can help in the observational study to rule out inexpensively over reasonable shortage of the diagnosis. And in essence, we have abandoned our quest for diagnostic perfections and accepted that instead of more mundane task of managing our uncertainty, we can safely be resolving it quickly and inexpensively if we employed these steps carefully. And yet, the study can cite that earlier, they can offer some hope that clinicians' cognitive ability can be improved by teaching trainees about the HRCS and providing opportunities for reflective practice, giving the physician feedback about diagnosis so they got the right and the wrong answer, encouraging their participating in conferences, which can be helpful in diagnostic error and deceptive and reviews. There is also a 12 tip for teaching the avoidance of diagnostic errors that seem to be useful as a starting point for these educational efforts. So, in light of the emerging popularity of these checklists in other parts of the safety field, as some of the authorities have even advocated the use of diagnostic checklists, both the general and the prompt clinicians to collect complete data and also engage in metacognition and specific ones that force the consideration of don't miss misdiagnosis when they can be faced with certain groups or even symptoms of signs that can be hard to diagnose. Also, developing patient-oriented checklists to help the patient become better stewards of their own health information and aid in the diagnostic process can be a reasonable implementation. Also, the theory behind diagnostic checklists can emerge out of cognitive psychology of the dual process model of thinking and also reasoning, in which state the clinician can engage in both type 1 fast, flexible, intuitive, and largely subconscious thinking, and type 2, the analytic, slow, and requiring focus attention type of thinking. Also, these checklists might help to prevent type 1 error by forcing the physician to slow down and overcome their innate diagnostic overconfidence. And while this is an elegant model and an appealing idea, a randomized trial found that the use of diagnostic checklists in the emergency room didn't improve the error rate at all. So further research to understand the full potential of such intervention is still needed. With another important point to consider, which is the system communication and information flow issues with diagnostic error. So while the discussion for this is far more important to emphasize the cognitive aspects of the diagnostic error, many of such errors can be on to more classic systems problems such as poor communication and inadequate information transfer. These problems can be subdivided into 5 domains, such as provider-patient encounter, diagnostic testing, follow-up, provider-to-provider interaction, and patient-specific factors. So these system and informational problems are likely to be more easily addressed than the cognitive ones that were described earlier. And for example, electronically promoting the clinicians to follow up on laboratory tests and X-ray should improve the diagnostic accuracy, and also as it should provide better access to specialty consultation, online evidence-based resources, and also up-to-date problem list. And one organization has successfully found that electronic health record to proactively identify the patient at risk for diagnostic error to be quite useful, as a researcher find that many ways that advanced information systems can help to prevent the diagnostic errors. So another important consideration is improving the ambulatory safety in regard to the patient income. So the implication of these ambulatory versus hospital differences are important as we turn our attention to the outpatient safety. And most clinics will be able to identify the areas in which adverse events are common and target their efforts accordingly. And these are likely to include improving the medication prescription, test results, follow-up communication, with also referring physicians and hospital providers with the patient engagement and education. Also, in a far-reaching discussion of a delayed diagnosis of renal mass, for example, the safety expert has found that higher number of the Swiss cheese model can be used along many opportunities for improvement in the ambulatory test follow-up. So while the advantage of computerized provider order carries the potential to decrease the outpatient prescribing error and also the growing adaptation of IT system, it has the potential to improve the safety of the ambulatory medicine more generally with a robust electronic backbone that is only one component of the SafeCare system. And indeed, a recent study of the EHR-related malpractice claims found that in which most of the cases came from ambulatory setting, they concluded that unintended consequences of healthcare IT are real and they are associated with adverse events which can cause significant harm. So, as with IT, in all healthcare settings, it is relatively easy, natural, even to think of it as the holy grail. If we just had good IT system, it is a common refrain to solve many problems of the associated health safety concerns. There is also no questions that there is need for system existing just to consider these sobering statistics as in a typical week, the average primary care physician is responsible for following up on 18 chemistry or lab tests, 40 radiograph, and 12 pathology specimen, where a recent survey study suggests that follow-up of test results remain a major concern for the primary care provider, where a fewer than half of the primary care physicians are also satisfied with their system for managing these test results, and more than 4 in 5 reports having had at least one test result as they wished they had known about it earlier in the prior 2 months before this issue has emerged more severely. Also, more often than not, some of the crucial pieces of information, such as lab results, and more often is being missed in the primary care visits. And another study showed that 1/4 of the time there is also missing result, and unfortunately, early evidence from ambulatory IT implementation demonstrate that IT is not a balance. And one primary care group can nearly broke up over the challenges that are accompanied by implementing new systems after the dust has settled with the physicians. And more recent studies has found that precisely that high rate of errors in both the medication and the radiology information flow can be even after IT implementation and early evidence that the presence of an ambulatory health record was even associated with improved quality that was even limited for some of the cases. So at the same time, it is inconceivable that we can achieve highly reliable ambulatory care without effective IT systems. And these results can illustrate, as always, that building and implementing IT is harder than it looks, and systems that need to evolve based on the provider and the patient feedback with human factors need to be considered in the development and also in the implementation of these systems. So, addressing these challenges is increasingly crucial as the adaptation in the ambulatory setting has grown rapidly over the last decade. And according to data from the Office of the National Coordinated Health Information Technology, up to 80% of the outpatient physicians had implemented some types of EHR by 2014. And while there are flaws in the healthcare IT system, as it continues to be well recognized, finding from a 2015 national survey of primary care has suggested that physicians recognize the potential of the healthcare IT to improve the quality and also the safety, with about 50% of the physicians and 64% of nurses, practitioners, and assistants responding to that implementation has had a favorable impact. In addition to this, more recent studies have shown a positive impact on the health IT adaptation on the ambulatory care. And as healthcare IT adaptation continue to grow rapidly, some of the commendable steps that can be taken to improve the ambulatory medication safety are also worth reviewing. And the role of the patient is crucial in the ambulatory safety, in particular since the patient spends so little time with their provider and far more time at home managing their own health. With strong emphasis that should be placed on the patient education and empowerment, in particular attention that is paid to the issues of health literacy and cultural differences. And overall, improving the safety in the ambulatory setting will not necessarily be harder or even easier than in the hospital, just different. And as with much of the patient safety field, which often involve exploring the experience from other settings, such as crew members and such, it will be important to remain sensitive to the differences in the structure and also the culture as we try to translate what we know about safety from the hospital to the office setting. And moving forward, the expert can suggest that research in the ambulatory safety should focus on several areas, as these include broadening the data on the epidemiology of ambulatory safety and focusing on areas where tangible improvement to prevent harm can be made. Also, improving the patient and the family engagement around the safety in outpatient care and tying the outpatient ambulatory safety to the high-profile issues like care of the transition or readmission, and also improving the infrastructure around the ambulatory research. And while the ambulatory safety was all but ignored during the first few years of the safety movement, research and funder with the regulator has become more appreciated of its importance, as have the patient and their advocates. Also, all of these stakeholders are now executing their influence, so the next decade is likely to see far more activity in the ambulatory safety arena and far more pressure to even improve. So the provision of healthcare is remarkably information sensitive, and therefore it needs to be considered carefully. Where a large integrated healthcare system processes tens of millions of information exchanged per day through even multiple pathways, including the electronic healthcare record, as well as via beepers, text messages, and even emails. And with high volume, that is just the beginning, we should consider the task of tracking a single patient with current disease, past medical history, and medication, allergies, test results, risk factor, and also personal preference. So this can even add to the fact that the patient is seen by many different providers that are scattered across the region that often use different medical record system and generally doesn't communicate with one another. And even to make a payment decision, the insurer needs to access some of this information, as does the source of the insurer, which is the related government. And because of the privacy concerns, both should receive only essential information to tell them of the patient's status or their medical history. So, assuming that the patient is in a car accident and taken to the emergency department in general, in the nearby state where they are stabilized and admitted to the hospital. And ideally, the doctor and the nurse would see the relevant clinical details of their past history, and preferably in a format that highlights the information they need without even overwhelming them with extraneous data. Also, the order must be processed instantly, and none of the system is down for the planning, maintenance, or any other related issues. So during the patient hospital stay, not only would there be seamless link among all of the new observations, which are the doctor's note, or even the resident note that find the patient's vital signs, also the various components that would wave together seamlessly. For example, the system would promote the doctor with information regarding the appropriate therapy or test for a given condition, including the links of the recommendations. So the system would warn the nurses that the patient is allergic to medication before they administer it, and the system would then tell the doctor or the pharmacist which medication are in the formulary regarding this patient-specific case. And the vast majority of the data being created through this patient case and millions of other like it would be chronicled and analyzed for new patterns of disease, evidence, and preferred strategy, and even more. And all of this would be even alliterative as new information emerged from this order and other research about disease risk factor or even best practice, as it would be seamlessly flowing into the system, and contrast to this vision of information nerving that are prevailing state of most doctor office and hospitals. And although that the federal policies have spurred rapid digitalization of the health information in recent years, about 90% of the outpatient physician and up to 96% of these acute care hospitals in the US alone were recorded as using an electronic health record starting from 2015. We should also note that often we have entered as pretext in a format of that facilitate the analysis or the productive interaction with other pieces of system data. So communication of facts such as medication lists, allergies, or other past medical histories, which should be streamed through the system instead, which is a part of mercy or even person-to-person interaction, or quasi-borders of the games that of the photocopy that can produce. So even at the level of the individual practitioner, the impact of this data chaos is profoundly demoralizing the wasteful and most importantly, dangerous method. By just watching a nurse take the patient vital signs on a typical hospital ward, then the nurse would look at the numbers of the screen and the automated blood pressure cuff, and then would write it down and then remove it to the patient file, where the resident will be disseminating these results in the rounds, and this can be taken to be implemented in the patient care. So these data can be presented to many health practitioners and be transmitted for many times, and doing this for many patients. So in any part of this process, an error can occur or an issue relating to the misinterpretation or the moving of the result. So a healthcare computer system have traditionally been relatively clunky and user unfriendly. In a part to fund vigorous research and development and to also generate the user feedback and refinement of the cycles that are needed for the complex reinforcement of these systems. And as the patient safety, this has catalyzed the widespread and recognition that robust digital scaffolding is absolutely essential to efforts of the quality improvement and safety efficiency and also coordination of care. And there are strikingly examples of success, such as the enjoyed of a huge veteran affairs success of the system, where they sparked a substantially improved quality of care. Also, a large and convincing literature demonstrated that well-designed and implemented electronic systems can lead to significant benefit for the system and for the patient. And yet there is more troubling thought of not entirely surprising side of this story. As over the decade ago, the safety expert has expressed that concern of the early glowing evidence about the HIT benefit, which come from a handful of institutions that are lovingly built on their own system, that are possessed with highly committed leaders, and also invested heavily in computerization. So the average of hospitals that will not share these conditions can be more than any local condition or primary hospitals, as there is more than one CIO that tried to airlift the commercial system into their own hospitals. And as we have already seen, the implementation of commercial IT systems at thousands of hospitals and hundreds of thousands of ambulatory offices might not be or may not go quite so smoothly and sadly have been proven to be correct. So, as growing literature tells the story of HIT implementation failure, the anticipated consequence and even harm can result. And indeed, this can be described as a series of medication error which occurred at our own hospitals with error that vividly illustrate how the unintended consequence of HIT implementation can lead to significant harm. So in this case, for example, a 16-year-old patient with chronic genetic immunodeficiency was supposed to receive antibiotic tablet twice per day, but this dose was written wrongly, and then this patient consumed overdose that led to near fatal grand mal seizure and therefore affecting the patient outcome. Also, this case is of sobering but useful tale that highlight the immense of challenges for the fundamental changes in the complex adaptive system, with critical need to use human factor designs principle and also overwhelmingly complexity of the underlying task, which might initially seem like a routine task. And the tremendous impact of the errors can have on both the patient as well as on the provider and nurse who care for them. So, describing the main type of HIT systems can include their safety advantage and some of the problems, including new kind of error as they can be created. And because the HIT addresses so many of the safety targets and is considered as a component of many solutions, a considerable information about HIT role in specific area can also be found throughout the book. So, in regard to the electronic health record, as most medical errors represent failures in the communication and also data transmission, computerization, and the medical record, that would seem as likely safe area to be considered. We should also realize this benefit of attention that must be paid to a variety of system and user factors, as system factors include the ease of use, the speed at which the data can be entered and also retrieved, with also quality of the user interface and the presence of a value-based added feature such as order entry, decision support, sign out, and scheduling systems. So user factors can primarily relate to the training and the readiness of the provider and the non-provider workforce. And both this systems and user factor played a role in the case of the Citra overdose described before. Also, this user efficiency is particularly important despite the hope that computerization would save time for the provider, and evidence indicates that the opposite is often true, in particular for the physician. So the user efficiency is particularly important despite the hope of the computerization, as many physicians now complain that they have become glorified data clerk entry as it can add to the workforce they need. And all of this has been associated with a troubling increase in the rate of physician burnout. So some of this cost in time may be repaid in more efficient information retrieval, but also the increasing attention need to be focused on the workforce. We should also remember that digital blood pressure reading in the wired hospital can be as a tremendous viewpoint for the electronic health record system to simplify the care for the patient and to enhance the safety concern. Also, effective system will of course provide a huge efficiency benefit of administrator, researcher, and insurer by capturing the data of the standardized format and allowing electronic transmission. but unfortunately, this can facilitate the movement of the bytes and bits of the dark side of the form and copy and paste phenomena. And one tongue-in-cheek can be captured through the copy and paste command, allowing one day to note to be copied and used as a template for the next day often. So ideally, the old information and diagnostic impression are deleted and the new ones are being added. And in reality, there is also no deletion, only addition, with daily progress notes that become progressively longer and contain sensitive information, with the admitting diagnostic impression with long since discarded with noted day to day after day. So the complicated patients are often on the post-op, for example, for 2 weeks, and some of their data are being copied and pasted in some of the sections. And a cohort study performed in the ICU on an academic medical center found that copying and pasting of the note can be prevented among both the trainees and the attending. And about 75% of the note examined were more than one-fifth of the content of the daily progress note copied from the previous day. So some IT system can be disabled by the copy and paste mechanism and can be as a simple solution for this issue. We will be taking a quick break for 5 minutes and then we'll continue with the discussion. So as we were saying, some of the IT system can disable the copy and paste method, which is a source for errors in the patient file. So this can be usually finding a way to bypass or even restriction way to prevent such issue. But other health professionals can find a way to use this copy and paste method without even the disabling option. So in the end, the copy and paste can resemble many elements of the patient safety in introducing structural changes without ensuring that the caregiver possess the requested education and professionalism that is likely to lead to a new type of mischief or even harm. So one important choice of the electronic health record developer is the use of a structured versus unstructured data. And the physicians in particular have always preferred entering data as unstructured forms, which has also the advantage of ease and the use of familiarity and also consistent with the long tradition of telling the patient story. While on the other hand, unstructured data are difficult to analyze for patterns and to use to support the quality improvement and the public reporting activities, and also to link the computerized decision support system. So the structured or coded data can be captured via templates or automatically fed into the electronic record after being recorded by electronic device, which can support these functions, but they can also clash with the clinician's mental model for the data acquisition. And ongoing research is attempting to identify the best mix of structured and unstructured input and also to develop new ways through computerized systems to mine the narrative flows of the key data elements. And one study performed in the Veteran Aware Health System has demonstrated that natural language processing with algorithms that could accurately identify the post-operative complication by screening the provider note. And this finding is supported by additional research that is likely to have the advantage of the electronic health record of the future. That it will be combined with best of both types of data to capture and to analyze, thereby decreasing the today documentation and information retrieval burden. In addition to this, another important advance is the ability to promote the patient engagement. And at the very least level, allowing the patient to access their own laboratory data and give them the ability to schedule their own appointment and representing real progress in their health impact. And as of this writing, there was about 10 million patients in the US having full access for their information. And while many clinicians worry that such access would lead to confused or even anxious patient evidence from several studies that has allied with these concerns. So the patients who are increasingly accustomed to managing their own affairs were far more likely to demand a new kind of tools to help with their own medical care and their overall health. And many patients now keep personal health records, and these are increasingly becoming electronic. So many patients can now keep their personal health record, and these are increasingly becoming electronic for the future development in this area that is are likely to weave the patient and the provider facing the electronic system together, even though that it can facilitate a new kind of information flow and communication, with also raising a host of issues surrounding the reimbursement, the liability, and privacy. And this can hold important implications for the patient's safety with the capacity of both for great leaps forward and some new hazards. So the EHR has raised yet another profound challenge, which, as the physician author has observed, the clinician's focus increasingly that is centered on the data of the computer that is sometimes at the cost of the human connection, so fundamental to the practice of medicine and also the art of healing. And after discussing the traditional approach to the patient, in which the patient body is the text, they found more expedient approach to that is seen in today's trainings. As the patient is still in the center, but more as an icon for another entity that is the binary garment. And often in the ER, the personnel have already scanned, tested, and diagnosed the patient. So the interns can meet a fully formed eye patient long before seeing the real patient. So this can be for the blood count or the emotion that are tracked and then trended like a dot. And these are handily discussed as the card flipped in the bunker of the conference room while the real patient is keeping in bed warm and to ensure that the folder bearing their names are safely presented in the computer. And taking the full advantage of the remarkable potential to improve the safety and the quality while also heading the various consciously of that it can be most subtle yet important challenge facing the caregiver in the modern age. So some of the general characteristics for the reporting system as the error report with the filled paper on through the web and whether the robust of the hospital safety officer and often to the regulator who can be divided into three main categories: anonymous, confidential, and even open sources. So the anonymous reports are the ones in which there is no identity for information that is asked of the reporter. And even though that they have the advantage of encouraging reporting, the anonymous systems have also the disadvantage of preventing the necessary follow-up questions from being even answered. And in a confidential reporting system, the identity of the reporter is known, but it is also shielded from the authorities, such as regulators and representatives of the legal system, except in the cases of clear professional misconduct or even criminal act. With such systems that tend to capture a more useful data than the anonymous systems because of the follow-up questions that can be asked. Also, the key to these systems, of course, is that the reporter must trust that they are truly confidential, and also that in an open reporting system, all people are placed in a publicly identified matter. So these systems have a relatively poor track record in the healthcare because of their potential for unwanted publicity and blame that is often very strong, and it is often easy for the individuals to cover up their error. While another distinguished feature of the reporting system is the organizational entity that receives the report. And with that in mind, let the first consideration of the local system managed by healthcare delivery and also organization of the IR system, including the systems that move the report to other entities beyond the clinical organization. Another important consideration for the patient safety is the reporting system for the hospital. So hospitals have long had IR system, but before to the patient safety movement, this system received little attention, if any at all. And in the traditional IR system, it relied on the provider, nearly always is the nurses, as the most studies has showed that nurse report out the number of physician report by at least 5 to every one patient. So this is to fill out a paper report and file it whenever there is an issue that needs to be reported. And these reports generally went to the hospital risk manager, whose main concern was often to limit his or her institutional potential liability. And as such, there was little emphasis on the system improvement and the dissemination of the result or the incident to the other systems. such as other manager, caregiver, or educator, which was unusual at the time. And most clinicians felt that reporting was waste of time, and therefore only few of them actually did it. And despite the growing emphasis on the patient safety reporting, until recently, the reporting system have been studied insufficiently. And based on a 2008 survey of about 1,600 hospitals across the US, the error reporting system described four key components of effective systems. But unfortunately, they found that only a minority of hospitals met these criteria. And specifically, only small fraction of hospitals showed evidence of a safety culture, which encouraged the reporting, probably by analyzing the error report and effectively disseminating these results of these analyses. And these failures are not for the lack of effort or, in many hospitals, the lack of investment. But in fact, many hospitals have invested heavily in their IR systems, and mostly in the form of a new computerized infrastructures completely. And the resources and focus that is needed to change the culture around the incident reporting and management to properly analyze the report and to even create useful and durable action plans have been less forthcoming than that of other systems. So with that said, the computerized systems do have their own advantages. For example, most systems can now allow any provider to submit an incident and categorize it by the error type and also the level of harm. And in a confidential system, the reporter can be contacted electronically to provide additional details if that was needed. Where in a computerized system, it can also make it easy to create aggregated statistics about reports, even though that it is important to re-emphasize that voluntary systems are incapable of providing accurate error rates. And as with other aspects of the digital data, increasingly the sophisticated analytic and artificial intelligence systems may soon be able to mine the IR data to even identify any meaningful trend and to suggest or even implement possible solutions for each case. And probably the most important thing is that the incident report can be routed to the managers who are positioned to take action or even spot the trend. But unfortunately, not all of the computerized IR systems have this function. And for example, when an error or penetrating to the medical service is reported through a hospital computerized IR system, then the system might automatically send an email to the chief of the main service, as well as the service head nurse, with the hospital risk manager and the category manager, and also the hospital director of patient safety. Also, each individual can review the error and have a discussion about it, either verbally over the phone or in person, or even within the IR system computerized environment, and also to document the action that was taken in response to this error. And even though that this represents great progress, it is important to appreciate the amount of time, skill, and even energy all of these functions can actually require. Also, many hospitals have their own built-in or purchasing fancy IR systems where their staff to report everything of all of the errors or the near miss, and also found themselves overwhelmed by thousands of reports that they couldn't handle to analyze properly. Also, a system that generated fewer reports but was able to act on these reports can have effective actions that would likely be more effective than one of the far more reports that end up in the black hole of the hospital drive. And in addition to using these informatic technology, using screen incident report for high risk events might be helpful. And as you can see, developing a thoughtful way to manage the data overload, whether the goal is to have or prevent alert fatigue in the CBO system, or even to handle thousands of error reports, which is an overreaching theme in the field of patient safety. Also, in an increasingly computerized environment and with the advent of trigger tools and other new methods of identifying the cases of error and harm, some of the patient safety experts are starting to question the role of the voluntary error reporting by the frontline personnel. For example, some would wonder whether every medication error and every fall really need to be reported through the IR system or not. And as we don't think perhaps that we should be sampling the common error categories in depth for both the short periods of time, we should consider an example of a system in which, for example, January fall month, February is pressure ulcer month, and so on, to have more focused attention on the error in specific and to gather more precise data on what can occur. So as a summary, we have defined the patient safety, the framework, and also the program development, including the most common area that can affect the patient safety, as we cannot also change the human condition, but we can change the condition under which the human work, as a main closing remark for our webinar. So this is the end of our course. I hope you enjoyed everything. We will be sending you all the slides over WhatsApp, inshallah. If you have any questions, please do send them on the chat. بإذن الله سيتم إرسال كل السلايدات لكم كمرجع تستفيدوا منها. الله يعطيكم بالتوفيق جميعا.